Okay, so thank you so much for inviting me to deliver this lecture. Next slide, please. Before specifically addressing the immunogenicity and efficacy of COVID-19 vaccination, I would like to briefly remind you that SARS-CoV-2 shall be reasonably considered the paradigm of a perfect storm for a variety of structural, biological, and clinical characteristics that are briefly summarized in this slide. Next one. This has persuaded many eminent scientists all around the world to conclude that there will be a huge risk that COVID-19 will become an endemic, probably seasonal disorder, more or less like influenza is. Next one. This means that the most likely scenario is that we shall be prepared to domesticate and live with this virus for quite a long time. Needless to say that widespread vaccination is the mainstay for domesticated infectious diseases. Next. And before starting the lecture on COVID-19 vaccination and the important, almost essential role that laboratory medicine has in the COVID-19 vaccination campaign, at least in my country, let me briefly introduce the concept of vaccination. The most eminent and influential definition of vaccination is obviously that of the World Health Organization, according to which this practice is a rather easy, safe, and effective means of protecting people against harmful diseases before they come into contact with them. Vaccination basically takes advantage from the connatural human defenses to develop resistance against specific infections, thus rendering the immune system much stronger. The post-vaccine immune response encompasses three essential elements, such as development of specific antibodies, which constitute the humoral immunity, training of specific immune cells to kill the pathogen, to kill infected cells, or even to produce immune mediators, which constitute the cellular immunity, along with the development of the so-called memory cells, which will help contrasting further recurrent infections. Next one. The enormous impact that vaccination has played, and it is still playing, in averting morbidity and mortality from infectious diseases has been brilliantly highlighted in this article, where it has been concluded that vaccination versus the 10 more common infectious diseases has allowed to save over 50 million lives in the past 3 decades and will expectedly permit to avert other nearly 50 million deaths in the next 10 years, most of which were and will be children. Next one. The fact that vaccine will play a major role in the fight against COVID-19 has been well described in this report, where it is shown that the addition of vaccination to systematic use of non-pharmaceutical intervention, such as wearing face masks, hand hygiene, and social distancing, may produce exponential benefits on COVID-19 related infections, hospitalizations, and deaths. Importantly, however, the major benefits can be seen when both widespread vaccination and usage of non-pharmaceutical intervention can be combined. Next one. As for other infectious diseases, but even more than in the past, many COVID-19 vaccines are increasingly becoming available all around the world. Next one. Several strategies are now attempted in formulating COVID-19 vaccines, encompassing vaccines based on inactivated virus, viral proteins, essentially the spike protein, as well as DNA and mRNA-based vaccines. Next one. One of the biggest challenges now is to establish development, efficacy, and duration of the immune response against SARS-CoV-2 after vaccination, which entails the generation of neutralizing antibodies directed against the spike protein or its receptor binding domain, along with cells that are primed to kill other infected cells or produce a vast array of immune mediators. Next one. The first important question to which we are called to provide an answer is indeed how COVID-19 vaccine efficacy can be addressed. We can basically divide the response into biological efficacy, which basically refers to immunogenicity and entails production of neutralizing antibodies, development of cell-mediated immunity and immunological memory, along with clinical efficacy, which is divided into several domains, encompassing lowering the risk of any type of infection, including asymptomatic infection, and paving the way to herd immunity, but also efficacy for decreasing the viral load, which would then imply milder disease and lessened infectiveness, lowering the risk of developing symptomatic or mild disease, preventing hospitalization or moderate disease, intensive care unit admission, or severe critical disease, and last but not least, for reducing the risk of death. Next one. Before specifically reporting on efficacy defined in terms of protection against SARS-CoV-2 infection and development of severe COVID-19 illnesses of the currently available vaccines, it seems however important to define which is the currently known efficacy of previous SARS-CoV-2 infections against the same endpoints. Next. This large Danish study, which has enrolled over 500,000 subjects, over 11,000 of whom with a formal diagnosis of SARS-CoV-2 infections and been followed up for approximately 6 months. It was finally found that the previous infection would provide around 80% cumulative protection against reinfection, becoming as low as 47% in subject age 65 years or older, thus underpinning that several doubts remain that natural protection, especially among older persons, could be relied on for a long time. Next one. Altogether, the clinical biochemical data that have become available so far has allowed to estimate the potential durability of the immunity against SARS-CoV-2 reinfection, which is likely comprised between 3 months and 5 years after the peak antibody response, with a median duration of 16 months. Next one. As instead concerned COVID-19 vaccines, an updated summary of the efficacy of the currently available formulation against SARS-CoV-2 and some of its emerging variants is summarized in this table, showing that the efficacy against infection and the risk of developing severe COVID-19 illnesses is between 50 and 95% and between 77 and 100% respectively, that may however decrease by 2 to nearly 9-folds versus some variants of concern, especially those bearing the E484K polymorphism in the receptor binding domain, such as the beta and gamma strains. Next one. A comprehensive analysis of vaccines' efficacy and their relationship with anti-SARS-CoV-2 neutralizing antibodies level has been provided in this study. The figure on the right basically reports such relationship, underpinning that some vaccines may provide higher degree of protection from SARS-CoV-2 infection, and this aspect seems to be substantially dependent on the neutralizing potential of the antibodies response. In other words, assessment of anti-SARS-CoV-2 neutralizing antibodies seems to be a honest surrogate of COVID-19 vaccine efficacy. Next one. In a following study, the same team of authors extended its evidence, highlighting that efficacy is not apparently the same for all the different vaccines, and that the relationship with anti-SARS-CoV-2 antibodies level is substantially retained, even when stratifying the data according to the different SARS-CoV-2 variants of concern. Next one. This same concept has received further support by this additional work, where a fairly good relationship has been reported between COVID-19 vaccine efficacy and both anti-SARS-CoV-2 neutralization and anti-SARS-CoV-2 spike protein IgG antibodies. Notably, the correlation found between COVID vaccine efficacy and anti-SARS-CoV-2 spike protein IgG antibodies was even better than that found with anti-SARS-CoV-2 neutralization. Next one. The favorable impact of universal vaccination on COVID-19 has been well demonstrated in this nationwide mass vaccination study in Israel, including over 500,000 people. Overall, the administration of the Pfizer vaccine was associated with efficacy of 46%, 57%, and 62% for preventing SARS-CoV-2 infection, COVID-19 symptomatic illnesses, and severe disease 4 to 20 days after the first dose, with vaccine efficacy increasing to 92, 94, and 92% for the same endpoints over 7 days after the second boosting dose. Next one. Italian real-world data confirms this same trend, with vaccine-elicited protection always higher than 90%, slightly falling to around 93% in the elderly. Next one. A reliable picture of the way humoral immunity develops after vaccination has been provided in our study that we carried out in Verona. Specifically, we have carried out a longitudinal assessment of humoral response in people receiving the 2 full doses of the Pfizer vaccine, who were sampled nearly every 3 days and followed up for 2 months after the first vaccine dose. As shown in these figures, total anti-RBD antibodies, anti-S1S2, and anti-RBD IgG levels increased between 91 to 400 folds until 3 weeks after the first vaccine dose, and then they reached a plateau. However, their values further increased after the second vaccine dose between 80 and 30 folds, peaking at day 35, but then starting to exhibit a slight but progressive decline with a trend towards stabilization at around 50 days. Importantly, NTS1 EGA levels increase instead between 7 to 11 days after the first vaccine dose, slightly declining before the second dose, after which the value only slightly increased from those reached at the first peak. Next one. In this survey that we carry out in nearly 200 baseline seronegative healthcare workers, we assay the immunogenicity again of the Pfizer vaccine, measuring the serum levels of anti-spike trimeric IgG, anti-spike RBD IgG, and especially those of anti-spike S1 IgA. Overall, vaccine administration elicited all anti-SARS-CoV-2 antibodies that we have measured. 30 days after the second vaccine dose, 100% positivization occurred for anti-spike trimeric IgG and anti-spike RBD IgG, while 1.7% of subjects remain anti-spike S1 IgE negative. The overall increase of antibodies level over baseline after the second vaccine dose was approximately 600 folds for anti-spike trimeric IgG, 1,500 folds for anti-spike RBD IgG, and 20 folds for anti-spike S1 IgE. Next one. The perhaps biggest challenge are, however, to establish the antibodies titer that may confer effective protection and the duration itself of such protection against SARS-CoV-2 infection, which may develop after vaccination. As concerned the former issue, this interesting study has concluded that the serum levels of 264 and 506 binding antibodies unit per ml of anti-spike and anti-RBD IgGs may confer 80% protection against primary symptomatic COVID-19. Next one. As then concerned vaccine breakthrough, which is currently defined by the CDC as identification of SARS-CoV-2 RNA or antigen in a respiratory specimen collected from a recipient of an authorized COVID-19 vaccine 14 days after the recommended doses. This has been estimated in the US with a frequency of around 1 in every 10,000 vaccine recipients, sustained by SARS-CoV-2 variants of concern in 64% of all cases. Other cases may include indeed immunodepression of different origins, which may be associated with a blunted or absent vaccine immunogenicity. Overall, only 2% of such patients died, while the remaining were all asymptomatic or died for causes that were completely unrelated to COVID-19. Next one. The reasons underlying breakthrough infection were explored in a study carried out in the largest medical center in Israel, where healthcare workers who received the Pfizer mRNA vaccine were followed up by means of RT-PCR or antigen testing, serological assays, and genomic sequencing. The first important evidence was that the levels of anti-SARS-CoV-2 neutralizing antibodies and anti-SARS-CoV-2 IgG were nearly 64 and 49% lower in infected subjects than in those with the uninfected controls. Overall, higher per-infection value of anti-SARS-CoV-2 neutralizing antibodies was associated with lower viral load, as attested by higher cycle threshold values. Next one. Reliable support to the concept that the serum levels of neutralizing antibodies may be a strong predictor of vaccine breakthrough comes also from this Vietnamese study, where AstraZeneca vaccinated healthcare workers who tested positive for SARS-CoV-2 infection displayed significantly lower values of these immunoglobulins, both immediately after vaccination and even 3 months afterwards. Next one. That said, the decision as to whether regular post-vaccination serological monitoring would be as advisable or not will depend on a tight balance between some advantages and drawbacks. As regards the latter, these surveys will enable to assess the baseline SARS-CoV-2 seroprevalence in recipients, will permit to quickly identify low or non-responders to COVID-19 vaccination, but also to timely detect a fast decay in the concentration of anti-SARS-CoV-2 antibodies. I am a paradigmatic case in such situation. The potential caveats include instead the current lack of definitive information on equivalence between anti-SARS-CoV-2 antibody titer, neutralizing activity, and vaccine efficiency, the fact that the cost effectiveness of different testing strategies is yet unproven, and last but not least, The huge volume of blood drawings and lab tests that may offset the currently available laboratory resources, more or less as it has happened before with molecular testing at the beginning of this pandemic. Next. So to conclude this lecture, these slides attempt to summarize the important contribution that laboratory diagnostics may provide to COVID-19 vaccination policies. Although we would all agree that the most important endpoints of vaccine effectiveness are clinical and basically encompass a medium long-term retrospective monitoring of the number of patients with breakthrough infections, hospitalization, mechanical ventilation, intensive care unit admission, and the overall number of COVID-19 related deaths, the use of surrogate measures may provide a fundamental help to more rapidly, almost in real time, and prospectively define vaccine effectiveness. The assessment of these endpoints is essentially laboratory-based and entails a serological testing, a surrogate measure of humoral immunity and anti-SARS-CoV-2 neutralization antibodies, interferon gamma release assays as a surrogate test aimed at deciphering and monitoring cellular immunity, along with flow cytometry for assessing memory B cells. Our strong feelings are that sooner this assay will become part of routine clinical practice, and we could thus optimize vaccine distribution all around the world.